and welcome to today's Consultant 360 webinar. Today's presentation is entitled Key Opinion Leader Webinar, Assessing Ovarian Cancer Risk with OvaWatch. My name is Julie Gould for Consultant 360, and we're very happy to have you joining us today. I'd first like to thank OvaWatch for sponsoring today's presentation. During the webinar, feel free to submit questions and comments for our speaker by using that question submission section on your screen, and at the end of the presentation, we'll try to answer as many of your questions as we can in the time allowed. I am very pleased to hand the presentation over to Victoria Haverbush.
Thank you very much, Julie, and I am very excited to be with you all talking about Aspira Women's Health and OvaWatch. As Julie said, my name is Victoria Haverbush. I'm Aspira Women's Health Director of Portfolio Development, and I'm excited to be here today introducing Aspira Women's Health as well as our speakers. Aspira Women's Health is dedicated to transforming women's gynecological health, starting with ovarian cancer. We've been leading the way in development of gynecological testing technologies for more than 20 years. Through collaborations with world-class academic and medical institutions, we've developed our OvaSuite of products. The two products in this portfolio are OvaOne Plus, the combination of two FDA-cleared tests, OvaOne and Overa, for women planned for surgery with adnexal masses. OvaWatch, launched in December 1st of 2022, expands this patient population to all other women with masses by providing ovarian cancer risk assessment for women with adnexal masses determined as indeterminate or benign on initial clinical assessment. We're excited to be developing a blood test for endometriosis that's planned to launch in 2023. And our products are distributed not only through our own sales force, but through various collaborations with other laboratory partners. I'm excited to be introducing our speakers today. Firstly, Dr. Leo Twiggs is Aspira Women's Health Director of Medical Affairs. He's a gynecologic oncologist and academic physician who's practiced gynecologic oncology for more than 45 years. He's Professor Emeritus at the University of Miami Miller School of Medicine in Miami, Florida. He's the past chair of the Department of Obstetrics and Reproductive Science and Associate Dean for Women's Health, University of Miami. He was the head of Department of Obstetrics and Gynecology at the University of Minnesota and internationally recognized as a teacher and academic scholar. He's authored and co-authored more than 200 peer-reviewed manuscripts and mentored more than 50 people in the subspecialty of gynecologic oncology. Joining us for our Q&A portion today is Dr. Andrew Bokor, Director of Pelvic Surgery at Ohio Health. Dr. Bokor has been in private practice for more than 27 years, practicing general obstetrics and gynecology with a focus on robotic GYN surgery. In addition, Dr. Bokor holds many administrative roles at Grant Medical Center, including chair of the Department of OB/GYN for 15 years, medical director of clinical services, and chair of the multidisciplinary peer-reviewed committee overseeing peer review for the entire hospital. He's recently been named director of pelvic surgery for the entire Ohio Health Hospital system. And with that, I will hand it over to Dr. Twiggs.
It's a pleasure to be here today to speak a little bit about the diagnostic tools that Aspira Women's Health has available for women with adnexal masses. There is certainly a clear need for better triaging tools, and this particular clinical situation is relatively common. You can see that the number of adnexal masses diagnosed in the United States today have been estimated at 1.2 to 1.5 million patients. Surgery is done for 200,000 to 400,000 patients, but only 20,000 patients have ovarian malignancy. Increasing the precision of diagnosis for ovarian malignancy would be helpful, as surgery is known to be life-saving in patients with ovarian cancer. We do know that surgical backlogs may delay high-risk patients from receiving the care they need. And we know that also that unnecessary surgery leading to surgical menopause causes premature ovarian failure in those patients. And that affects the quality of life and increasing other disease risks. Next slide, please. So when we look at the ACOG adnexal mass guidelines, management guidelines, you can see that there's basically three categories that we look at after we've had the pelvic mass detected in the ultrasound. We can see three categories. Obviously, when it's clearly malignant, the patient should be seen by the gynecologic oncologist. CA-125 baseline monitoring should be done, and the oncologist should take care of the clinical situation at that point. When it's clearly benign, the patient can be followed, doesn't need to have surgery, doesn't need to have ovarian removal, and watchful waiting management of symptoms. The problem we face, however, is that we've noted from some of our studies that there's an indeterminate group where the formal risk is not understood. And this is an area where precision needs to be done. And the tests that we have developed help us decide whether to refer the patient to GYN oncologist or to have the patient further imaged and followed. Next slide. So again, this concept of uncertain in the middle, the pelvic mass detected in an ultrasound, the indeterminate masses, is a current diagnostic dilemma. And you can see that the previous studies have shown between 18 to 31% of adnexal masses are considered uncertain. We will show you some data that shows that this may be even higher, up to 50%. So again, what is the risk, and how do we handle this? If it's probably benign, we can do watchful waiting and management of symptoms. That's clinical management. If there's a high risk for ovarian cancer based on the ultrasound, based on the imaging, based on our tests, then that patient can be referred for surgical management by a GYN or GYN oncologist, depending on the surgical skill of the clinician. Next slide, please. This is a study that Dr. Dunton and Kate Stampler did for looking at 1,283 radiology reports with known surgical pathology results, which is independently analyzed in blinded reviews by 2 of 5 experienced clinicians. Again, the clinical assessment parameters were benign, malignant, indeterminate, or not enough information, insufficient data. And the key findings, noting that reviewers had concordance of 73% of the cases, the indeterminate impressions accounted for 50.55% of all cases. And in those, 69.81% of those were concordant. Therefore, we feel that this indeterminate situation of ultrasound findings leads to a clinical situation where we actually could help with some of our diagnostic testing that we've developed. Next slide. So the typical management of a suspicious ovarian cancer patient, the patient presents with vague abdominal bloating and is recurring frequently. The patient does the internet search, finds out that the abdominal pain can be many things, causes confusion and frustration. Next slide. She visits her OBGYN if she gets a chance to get in the office. The physical exam is often unremarkable, and the good clinician will include ovarian cancer in the differential diagnosis. The complete workup includes orders for ultrasound and blood work. And while waiting for her appointment, patient starts to worry, consults with their friends and Dr. Google. And again, at the ultrasound, they find a 6 centimeter mass, few suspicious features, and not overly malignant, and it's ruled indeterminate. Unfortunately, lots of patients get surgery at this point in time. And it's possible that we can allay the patient's fears and follow the patient rather than have her schedule surgery, remove her mass, and possibly removing the ovaries. Next slide. So there's no question there's a lack of effective diagnostic tools which result in negative outcomes. Look, from the patient's perspective, the assessed risk is low, but certainly they think they have ovarian cancer. We know that delays in diagnosis and treatment decrease overall survival. And if the surgery performed by a generalist and a second surgery is needed by the gynecologic oncologist, then obviously that reduces the quality of life in this particular patients. When the assessed risk is high and no malignancy is present, there's obviously lots of anxiety. We don't want to do unnecessary premature surgery causing complications, and unnecessary referral to GYN oncologists leading to longer wait times for people who really need their specialized care. Next slide. For physicians, however, the clinical situation is also different. So the lack of effective diagnostic tool results in negative outcomes for the physicians. They have scrutiny of their care, referrals of patients that could continue in their care, delays in the care of high-risk patients, reduced ability to provide quality care because of the number of patients. Obviously, increased costs associated with premature and unnecessary surgery result in high healthcare costs and increased costs for long-term treatment and surgical menopause. There's an increase in financial burden when the diagnosis of indeterminate is not carried out properly. Next slide. How can we improve the outcomes for women with benign or indeterminate adnexal masses? Well, let's have Victoria Haverbush tell us how to do that.
Thank you, Dr. Twiggs. I'm very excited to be here talking with you today about OvaWatch, which is our new ovarian cancer risk assessment assay for women who have adnexal masses that have been determined by initial clinical assessment as indeterminate or benign. This is a blood test which evaluates 7 different biomarkers through a proprietary machine learning-based algorithm. In addition to the 7 biomarkers you see on your screen here, which include the well-known CA125 and HE4, our algorithm also includes both age and menopausal status. This algorithm generates an OvaWatch score, and you'll see on the report in just a few slides how this looks on the report for you to evaluate with your patients. OvaWatch is an exciting addition to the OvaSuite portfolio because it expands our existing ovarian cancer risk assessment test to an earlier stage of adnexal mass workup. As I mentioned earlier, our other test, OvaOne+, which is the combination of 2 FDA-cleared assays, OvaOne and Overa, really is intended for those patients who have an adnexal mass that are going to surgery. OvaWatch is intended for those patients who are either having a mass that is seeming benign on imaging or indeterminate on imaging. So the result of that is often that those patients are actually not proceeding to surgery at this time, and OvaWatch is able to give both the doctor and the patient additional confidence in staying out of the surgical suite because the risk of malignancy is low. This test is optimized towards negative predictive value. The negative predictive value is more than 99% for OvaWatch, so you can feel confident in a low probability of malignancy result. As Dr. Twiggs mentioned, indeterminate adnexal masses are extremely common. They're seen between 18 and 31% of the time, and perhaps even 50% of the time in community settings. So OvaWatch can help refine that large group of indeterminate masses to different groups that maybe truly are indeterminate, or more importantly, actually have a very low probability of malignancy, and the doctor can take that into account when planning the patient's management. OvaWatch has 2 peer-reviewed studies associated with it. This is our most recent clinical study published in Frontiers earlier in 2023. OvaWatch was shown to have clinical validity across patient cohorts. These were large-scale studies with real-world patients. The negative predictive value was greater than 99%, and in one of the cohorts, OvaWatch identified 18 of the 22 malignancies that were missed by clinical evaluation. That means that in this cohort, OvaWatch did provide an additive value to what the clinical assessment initially consisted of. We also have some exciting things coming for OvaWatch. These 3 abstracts were accepted for publication and published online in 2023 by the American Society of Clinical Oncology. The interim data from these abstracts lays the groundwork for a lot of exciting uses for OvaWatch in the future. These abstracts cover the initial data for OvaWatch perhaps having a role in preventing unnecessary surgery, possibilities of OvaWatch as a serial monitoring or longitudinal monitoring tool in the future, and lastly, how OvaWatch compares head-to-head with other ovarian cancer risk assessment tests for those patients that present with indeterminate masses. You see on your screen here what the OvaWatch clinical test report looks like. You'll see the OvaWatch score that's boxed in the upper left of the report. The OvaWatch score goes from 0 to 10. Anything below 5 is considered a low probability of malignancy result. That kind of result gets an associated NPV, or negative predictive value. Again, the OvaWatch negative predictive value is extremely high, and it's calculated based on the OvaWatch score for that particular patient. So you see that this particular patient had a low probability of malignancy, negative predictive value of greater than 99%. So that doctor and patient can feel confident not pursuing surgery at this moment and pursuing that clinical management approach. You'll also see that the OvaWatch report on the very bottom includes both CA125 and HE4 biomarker results as an individual readout. We know that many clinicians still like to get that CA125 result and that HE4 result. So we've included them on the test report to ensure that you get the benefit of CA125 and HE4, but you're getting the additional benefit of the OvaWatch algorithm as well. So ordering OvaWatch does not mean you lose out on that CA125 level. You absolutely still receive it. You just receive all the other benefits of OvaWatch along with it. Here we have an example case study for how OvaWatch might be useful in practice. Now, I want to be clear that the ultrasound here and the test report are just examples. These are not indicative of the actual case. However, this clinical scenario is based on a scenario previously described by one of our collaborating clinicians. In this case, an elderly postmenopausal female had an incidental finding of an adnexal mass on imaging that was initially done for joint pain. Many of the physicians on the line will likely validate that adnexal masses are pretty common incidental findings on other types of imaging. And even though it's not causing any problems right now, the question becomes, what do I do with this mass on this patient's ovary and how do we move forward? In this case, the patient had a 7-centimeter mass. And even though there weren't overly malignant features of this mass, the patient's age, being elderly and postmenopausal, and the size of the mass was somewhat concerning, and the physician wanted some additional information. This is the perfect opportunity to order OvaWatch, because as soon as the patient hears that there's a mass on the ovary, the initial response might be to go straight to surgery. But in this particular patient's case, there were family obligations coming up. It really wasn't an optimal time to pursue surgery. This is the perfect time to order OvaWatch. In this case, the OvaWatch report came back low probability of malignancy, giving both the patient and her physician confidence to delay and perhaps even indefinitely delay the surgical discussion until after these various planned family engagements. Without doing OvaWatch, the provider and the patient would have been left with that probably discussion that the mass probably isn't benign. Doing OvaWatch enabled the patient and the provider to get their hands around what the actual ovarian cancer risk was for this mass. We've designed the OvaSuite of tests to really mimic what the clinical workflow looks like for patients with adnexal masses. Now, with the addition of OvaWatch, OvaSuite has a test available for any patient with an adnexal mass over 18. If you see a patient who has an adnexal mass and that patient is going to surgery, either because there's a risk of malignancy that you see on ultrasound or because the mass itself is causing problems such as pain, if a mass is going to surgery, if that patient is planned for surgery due to her adnexal mass, OvaOne Plus is the test from the OvaSuite portfolio to choose. OvaOne Plus provides a risk of malignancy so you understand what the risk is for that mass going into surgery so you can make an informed decision about whether you as the gynecologist will be performing that surgery or if it's appropriate to refer that patient out to a specialist such as a gynecologic oncologist. We've also talked about OvaWatch, the most recent addition to the OvaSuite portfolio. As a reminder, OvaWatch is intended for an ovarian cancer risk assessment test for patients who have an adnexal mass evaluated by initial clinical assessment as indeterminate or benign. Because the masses that are indicated for OvaWatch are not inherently malignant appearing on ultrasound, because those masses would be routed for surgery, OvaWatch is really intended for those patients that are on a clinical management pathway. It's intended for those patients where you might be evaluating whether or not a watch and wait approach would be appropriate. OvaWatch, with its high negative predictive value, enables you to confidently trust a low probability of malignancy result and feel comfortable not proceeding immediately to surgery with that patient. Getting results with OvaWatch and OvaOne Plus is extremely easy. You can collect samples for both tests using the specimen transport kit, just filling out a test requisition form like you would for any other test. And you send the sample to us to our laboratory in Austin via prepaid FedEx service. There's also the option to order via partner laboratories. Our partner labs include BioReference Laboratory, ARUP, Health Labs, Ward Medical, Clinical Pathology Labs, Women's Care, and many more. So really, there are many ways to order OvaOne Plus and OvaWatch in your practice, and the results are always faxed to your office within 1 to 2 days. To learn more about our test or to order kits, you can either call the number or email on this screen. You can also scan the QR code, and that will take you to an order form where you can order our kits directly from our website. Thank you so much for your time today. And with that, I'll hand it back to Dr. Twiggs and Dr. Andrew Bokor. Thank you so much, and really excited to be here with you all, as I said, going over some of your questions. So first question we have is for Dr. Bokor. So Dr. Bokor, we've just heard about OvaWatch and the benefits of the test, but in your position as Director of Pelvic Surgery, what's your opinion on the utility of this test?
I think, as was discussed in the presentation, the significant value is the negative predictive value. I think all day, we take care of and try to figure out what to do with these indeterminate masses. The benign ones are easy. The cancerous ones are easy. It's what do we do with the ones in between? And nobody wants to get caught at 2:00 in the afternoon in the OR having to call Dr. Twiggs to come do staging for a missed ovarian cancer. So the negative predictive value of being able to keep the patient in your own office, they're not sitting in the GYN oncologist's office with other cancer patients when they very likely don't have a cancer, is really significant, and it saves time, it saves money, it saves referrals, and it gives patients peace of mind.
Yeah, I could just an aside. I think that one of the things we could do with this test, if it turns out to be low risk, is that it may obviate people doing surgery and removing ovaries unnecessarily, at least just for diagnostic purposes. And that allows people to have their ovaries for a longer period of time and receive the benefits of ovarian function. And that has been, a number of papers have been written recently showing that ovarian resection and menopause caused by ovarian removal does have significant health consequences for the patient.
And going over to Dr. Twiggs, as a gynecologic oncologist, what's your opinion on this test being performed before the patient is seen by someone such as yourself?
Well, the dynamics of referral are complex, and one of the ways to focus is rather than all the other myriad decision making that is done is to be patient centered. So this particular test, done in the hands of any provider, really, gives them some confidence of whether or not there's cancer there, and this allows them to consider the patient first, number one, and number two is make a proper referral at the time it needs to be done.
Anything to add to that, Dr. Bokor?
No, I think Dr. Twiggs, said it exactly the right way, is that it gives us confidence that if we're going to follow something, that it's okay to follow it. I think it also helps address the urgency of the referral. The patient has a mass and, they all want to get in yesterday to see the GYN oncologist. We all know that their life happens also outside of indeterminate pelvic masses. And so I think it helps allay fears of does the patient need to be seen tomorrow, or can the patient be seen in 6 weeks, or does the patient need to be seen at all? And I think that's really important. At our institution, the GYN oncologists have enough cancer. They don't need to operate on benign masses. There's a great saying, if you walk into the barber shop and ask the barbershop, do you need a haircut? You're going to get a haircut. And so it's hard for a GYN oncologist to get a mass in the office and say it's okay not to operate. So I think, it keeps referrals in the right place also.
Thinking about over the course of your career where you've done a lot of surgeries, where do you think, thinking back on maybe a particular case or maybe a particular practice, what would have been the factors in making a test like this even more useful, or things that you wish you had had previously be able to use this test in your previous practice?
I really think what happens is without this test and an indeterminate mass, a generalist or even a family practitioner is left really with no option other than to refer the patient to the GYN oncologist. Because as I said, nobody wants to be calling the GYN oncologist at 2 p.m. To stage the patient appropriately. And so it would have been nice over the many years to be able to like I said, keep this patient locally, keep this patient within my own office, and refer the ones that need to be referred.
Yeah, I would agree that one of the things that is that's important is the availability of the GI oncologist in the operating room, and each system has its own myriad of availability. Some people have a person all the time that's available. Sometimes you have to transfer hospitals and go to a different hospital. So consequently, that makes it more difficult. So understanding in your clinical situation where the GI oncologist is and what happens is important. But again, most providers probably won't know all those details unless they do a lot of gynecology or a lot of gynecological surgery. Again, it's really important to understand the system you're working in, and I'm sure this test is going to be much more useful when the system is more diverse and patients have to be transferred from one place to another for the proper surgery.
And one thing that was discussed in this presentation was the differences in maybe the incidence of indeterminate masses between academic and community settings. This question is for you both. In your perspective, how might the use case of this test be different in a community setting versus an academic setting, if you have any insight to that?
I think it's very useful. We discussed OvaWatch at an academic institution where the GI oncologist said, well, I'm always available, so I can always operate. And that's just not the way it is in many either rural or community type settings. And, the hospital systems are getting bigger and bigger, and they have hospitals that are part of their referral network. And if a patient lives an hour away and in a rural or a non-academic setting, it keeps the patient at home also. It keeps the patient having surgery in your home if they're going to have surgery. It keeps them out of, again, like I said, it's the value of this test lies in the negative predictive value of it. And that's where, as a general OBGYN, that's where I find it most useful.
Have you seen the incidence of masses deemed indeterminate really fluctuate from setting to setting, or has it been relatively constant in your career?
I would say that as our ultrasound technology has gotten better, that we can find more details in these masses, whether it be septations, whether it be solid components, excrescences. And so without doing more than just ultrasound, without doing CAT scans and MRIs, it's also dependent on your ultrasonographer. There used to be an OBGYN sonographer, and now you have maternal fetal medicine OB sonographers, and you have GYN sonographers, and they're very good. And this is not just the blood test; it's the blood test plus the menopausal status, plus the ultrasound findings, plus your exams. So it's an entire constellation. But I do think that we're finding more and more what I like to call incidentalomas, that somebody got imaged for something else that was, 72 years old. Now you have this mass that the patient's uncomfortable sitting on, but you have a test that helps her say, you know what, maybe we don't have to do anything about this. And indeed we can just watch it. So ultrasound has just gotten so much better. We're finding more. So finding more and operating on all of them is not the answer. Finding more and knowing what to do with them is really what we're looking for.
Are there any particular patients where that is perhaps a bigger question than whether or not to do surgery to begin with, is the timing of it?
Well, I mean, I certainly think that when you're finding these asymptomatic masses, rushing off to surgery is not something that you want to do, number one. Number two, if we're finding them in 72 and 74-year-old patients or 65-year-old patients, they have more comorbidities. And somebody like Dr. Twiggs, who probably can comment on operating on people with comorbidities, because cancer patients are older. But if you have other comorbidities and you have something that says this doesn't necessarily need to come out, I think it's certainly a value. It's a value in my hands if I don't need to make a referral. Once a referral is made, Dr. Twiggs can then help decide with, what to do with it based on what happens in life. I mean, people have, relatives getting married and kids getting married and other things that they may want to put it off for 2 months. And this can help with that also.
I would agree. That's a good way of looking at the test. The referral to the G1 oncologist becomes problematic, especially when they're not available or they're super busy. The other thing too is we're not trying to find expectant management so those patients can plan their lives, just like you said, with respect to what's happening in their lives, and they don't have to jump into feeling anxious and getting things done right away. And so consequently, the other thing I want to talk to a little bit is that precision of ultrasound has gotten better over time. But again, one of the nice things, I think Dr. Bokor talked about it in a previous discussion, was the fact that when you have a GYN ultrasound person, if you can communicate with that person what the pathology was, and then they can do a pathological confirmation of what they saw on the ultrasound. And I think that's really helpful to educate our ultrasonographers in the more complex masses.
For the patients that you've seen, when thinking about how the OvaWatch test would resonate with them, not necessarily as a clinician, but as a patient, do you have anything to add regarding what value this might have for the patient themselves?
Well, in OvaWatch, we're also talking about, a lot of times we're talking about older patients also that we use this in. And you have patients with comorbidities. And, you have a 42-year-old patient with an adnexal mass versus a 70-year-old patient with diabetes, hypertension, and had a previous heart stent. And so I think that's one of those other things that, again, it goes back to you're not ordering this test in a vacuum. And so I think in the patient that might be a higher risk, or that multiple previous surgeries that might be a higher risk, it gives you and the patient more comfort that, considering the risk, it's okay to sit and watch this. Dr. Twiggs, operates on patients like this all day and every day. And so, but it's different for the benign gynecologist. And that's really the people that are ordering this. I mean, the patients are coming to the GYN oncologist with this, test already in hand. And so it helps further triage and using the surgical risk status of these patients also, that it's okay to not operate.
Yeah, if you have a test, for example, that's not low risk, then the gynecological oncologist will probably operate. That again, that gives you a chance to understand that you have to have the surgery. If the test is low risk, then again, we don't have to operate on somebody who's got all these comorbidities. And we're operating on patients that we 10 years ago we never would operate on, because the laparoscopy has gotten so great, and the anesthesiologists have gotten better at they know how to put patients to sleep and keep them aerated and so forth. So there's it's just a bit of paradigm shift in the quality of perioperative care and laparoscopy over the whole country. All these people are getting trained and so forth. So but it's still there's no such thing as a simple surgery, and it's important for us to realize that surgery does have side effects, and we have to be very careful in making sure we operate on the patient who really needs it.
And I know we've spoken quite a bit about the OBGYN space, but I'm sure there are folks on this call who are outside of the OBGYN space, perhaps family medicine, perhaps in emergency medicine. So from your perspective as a gynecologic oncologist and an OBGYN, what value do you think this test might have outside of the GYN space?
I think it, patients usually get to the GYN oncologist through the OBGYN, from their family practice nurse practitioner or the family practitioner to the OBGYN and eventually to the GYN oncologist. So I think if you're practicing medicine, in a rural area, I think if you're a nurse practitioner, I think if you're at limited access, it's just another tool that you can use to reassure the patient of either it's okay not to go an hour and a half away, or the other part of it is, and we've been talking about negative predictive value, the other piece that Dr. Twiggs just mentioned is, yes, there is an increased risk. This test does show that there's an increased risk. And I know you don't want to go an hour and a half away, but it's in your best interest to do that. And I think you can have that conversation with the patient too. So I think there's utility for multiple referrals that can be saved, or multiple referrals that do need to be made in the primary care world.
I would agree that in the complex world, oftentimes the patient is seen by very skillful nurse practitioners and PAs. And these people have been actually some of the early adopters of our test because they see the patient first with anxiety and so forth. And they oftentimes don't want to go to the gynecologist. And the gynecologist is sometimes hard to get into too. So again, these providers have been very helpful in talking about our test and the test in those patient populations.
And thinking about OvaWatch and the biomarkers that are made up of it, one of the questions is that the OvaWatch test measures certain proteins in the blood, including CA-125. Yes, I can answer that. Absolutely true. And on the report, you receive the readout of both the CA-125 individually. What's the value of that report to you as a clinician that you receive those biomarkers? And then what's the additive value of receiving the remainder of the OvaWatch report?
Well, I think for those of us who grew up on CA-125, you still get the value, you still get the number. So if you're looking for that number, it still comes in the report. The benefit is that you have all these other biomarkers that additively add up to a more sensitive test. We know that OvaWatch, both sensitivity and specificity, are so much better than just CA-125 alone. And so, we can't use it longitudinally right now. Dr. Twiggs probably can answer to that better than I can. But if you want the CA-125, it still comes in the report. It's just you're getting so much more with OvaWatch.
Why do we have the option for OvaWatch to reflex to OvaWatch Plus, for example? Because as we talked about in the presentation, OvaWatch is really optimized for that negative predictive value, whereas OvaWatch Plus is optimized for a slightly different use case. And I wanted to answer that here, and that the reason for that is because the indication for OvaWatch, as Dr. Twiggs said, is for those patients that are not going to surgery. OvaWatch Plus is inherently those patients going to surgery. And that's why one can't reflex to the other, because the indication would have to change between one test being run and the second test being run, which is something we can absolutely do as the lab, but that order has to come from the clinician. All right, so moving on down to a question for my colleague, Tony Preston, who's on the line. Is the OvaWatch test covered by insurance? If you could cover any of the patient pricing information.
Yeah, thanks for the question. So first, let me say that we are certainly passionate about what we do. And with that comes a high level of commitment to make sure and ensure that every patient that needs our test has access regardless of their financial situation. So as far as coverage, OvaWatch has good coverage. OvaWatch has realized increasingly good reimbursement since launch at the beginning of the year. If our test is a covered benefit, of course, the patient would be responsible for their deductible and their copay. Under our patient transparency program, if the test is not a covered benefit, the max out of pocket for that patient would be $295. $295 is also our cash price. And as far as notable national plans, we are covered both OvaWatch and OvaWatch on Cigna. And we also have coverage on Medicare and TRICARE.
Great. Thank you so much, Tony. There was a question in the chat about whether or not we rely on age or menopausal status. And really, when we're requesting menopausal status on the requisition, it's truly their menopausal status, not based on their age. So what is the physician's assessment of their menopausal status?
Definition of postmenopausal: 6 months without a period. Postmenopausal.
I think, Victoria, we're talking about this test like it's in a vacuum, and it's really, it's the entire picture. The test gives you a number, but you still have to use the physical findings. You still have to use the ultrasound report. Dr. Twiggs mentioned earlier, a lot of times the physical findings are pretty benign, but the ultrasound and the features of the ultrasound, I think, also help. And in the OvaWatch test, it is in the report, it's part of it is the menopausal status and the ultrasound findings. And we just know that ultrasound findings in postmenopausal patients have it, make you raise your eyebrows more. So this test isn't the OvaSuite of tests isn't done in a vacuum. It's done along with clinical findings and ultrasound findings. So it's putting the whole thing together. And on the report, it actually has different categories for premenopausal, postmenopausal, and high-risk ultrasound and low-risk ultrasound. So I think you got to keep in mind, you're not relying on just this blood test.
It certainly is just one piece of the puzzle. And that can certainly be challenging when it comes to ovarian masses, because they might appear one way on ultrasound and the other way, for example, when they're removed via surgery or with later imaging. And we did have a question come in regarding when to order germ cell panels. So for those who don't know, there are some additional options on the Aspira Women's Health requisition form, for example, a germ cell panel. So Dr. Twiggs, the question for you would be when to order this germ cell panel and perhaps how to interpret it when those results might come back elevated.
Yes, we've had a number of questions about that. People order the germ cell panel and it comes back mildly elevated, and what to do. So most of the time, germ cell tumors are seen in younger patients, and so patients who have adnexal masses in younger patients, and what is that? It's you know what younger is, 1 year younger than you are, but premenopausal. Let's put it that way. So again, I think a solid tumor, a tumor that has, but oftentimes when the ultrasound is complex, then we're not talking about indeterminate. We're talking about a patient needs surgery, and when you think in your mind that the patient needs surgery, if that's how you're thinking of them, then that's the time to get those germ cell tumors, so that you can enter the operating room and the GU oncology office, or if you do it, the patient yourself, if you're skillful at that. That you have counseled the patient on the various aspects of those kinds of strange tumors. I like to hear Dr. Bokor's comment on that too.
I think it's the solid pelvic mass that I would use it in. If you had some other biomarker, if you're for some reason you ordered AFP, HCG, something like that. But really, it's the solid tumor in a young patient. That's where I see the utility in it.
All right. So I really appreciate everyone joining us today. Thank you so much for all the great questions.